Thank you.
Yep. Hi, doctor. How are you?
Doing good, doing good. I'm sorry for confusion.
That's all right. Not a worry. We'll make it work.
I just want to make a request. I have another
Sure.
commitment so if I can be done by 2:05, I would appreciate that.
Of course, we'll make that happen. Not a problem at all. Let me begin, of course. Let me begin by explaining some context, and then we'll jump to the questions. So as background, I work with an independent market research company. We do only medical work. I'm a pharmacist. I specialize in oncology. My client today has an interest in the management of metastatic non-small cell lung cancer. And so you and I will do a brief review of your current treatment approach, and then I would like your feedback on projected data for 2 different products. So that's what we'll cover. Everything you tell me is anonymous. I have no vested interest in how you answer. Please do be honest with your comments. Know that we're being recorded. That's a note-taking tool, and I do have colleagues listening on a muted line. So that's the scoop. Can I clarify anything?
No, ma'am.
All right, good. Let's do a brief review. Brief review of your practice, 16 years in practice, community-based oncology, correct?
Yes, ma'am.
What else should I know as context for your practice?
Nothing really. I mean, it's a community-based practice. We see, solid tumor about 60%, 40% benign in malignant hematology. And we see everyone from every walk of life, and our main cancers predominantly is the lung and breast.
Privately owned or part of a network?
It's a hospital-owned practice.
Great. Typical month for you, doctor, how many different patients do you see? This would be all diagnoses first, new, follow-up, everybody.
Yeah, so I mean, in a month in a month, am I right? About 300 patients. Yeah, 300 plus.
Of those 300 plus, how many have non-squamous, non-small cell lung cancer?
I mean, as I said, it's one of the 10% plus, patients will be lung cancer.
Around 30, give or take. And then one other proportion to learn would be the fraction of your non-squamous, non-small cell patients who are unresectable.
That's a very good. That's the majority of the practice is stage 3 and 4. I mean, that's the mostly those are the patients who are getting systemic treatment. Yes.
Yep. So majority being what fraction?
Majority, you would say 70% are stage 3 and stage 4, and only 20 to 25% patients will be early stage 1 and 2.
Perfect. I got it. All right. I'm switching my screen here such that you can help me with some projections about current treatment. So you'll notice as this comes up, giving me a little bit of a delay. Here we go. We are focused on second line, metastatic non-small cell. All comers, including those with targetable mutations. But in the second line setting, I'd like to understand how your treatment approach would fall among these different options. Let's presume you have this 100 patient group to treat. How many would be in each bucket?
Well, I mean, so let me get this clear. And those are including with the mutation as well?
That's right. Okay. That's this line here.
Yeah. Yep. So, I mean, it's a kind of a little bit difficult, but let me tell you, majority of the patients are getting, it depends upon what they got in the first line, am I right? So majority of the cases, patients do get, let me tell you, platinum, they get a first line, they get a checkpoint inhibitor in second line, not so much anymore. EGFR ALK inhibitor. So majority of the cases, so let me explain to you. So majority of the cases either they are getting the EGFR TKI in the first line, either they are getting the chemo in the first line or chemo immunotherapy or immunotherapy alone. So most of the time, majority of cases do get a docetaxel and ramucirumab. Okay. Okay, so that will be the one context now. Other context will be, other patients will be, single agent or double agent. Now the second line, sometimes we do second line TKI, such as an ALK, we will do a second line TKI. So I would say, 80% of patients are docetaxel or ramucirumab, and 10% will be immunotherapy, monotherapy, which is 10, and 10% will be a TKI. It's kind of not a good explanation, but that's closest I can
that's
come
fine.
up.
That's all I need for now. That's perfect. Yeah, thanks. So let's back up in terms of the patient presenting with metastatic non-small cell and qualitatively talk through your testing approach. Let's start there in terms of the biomarkers. What is the approach today?
Well, I test everyone for, I do the next-gen sequencing on everyone. So NGS on almost every stage 3 and 4.
Great.
So that's not a question anymore. That do we test? We test everyone.
Fair enough. And then clarify for me: is this sent out to a third party, or can you do it in-house in your hospital network?
It is sent out as a third party. We don't do it now. It's a community hospital, so they don't have any capability.
Oh, fair enough. Right. Tissue typically, or are some of these patients a blood draw? You're
right. Always attempted to get the tissue. If the tissue is not available, then the liquid biopsy and
is your backup. Okay. Yeah. Super. As you look at the results of this biomarker testing, help me understand which mutations are most relevant and what you're looking for.
Now it's about 8 mutations where we are interested because there is a consequence, the treatment implications. So we look for everything: EGFR, ALK, ROS, and BRAF, and then it comes to the new one, which is RET mutation, or fusion, either one. And then also we are looking at the MET-exon 14, and of course we look for the PD-L1. Did I miss anything else? BRAF, probably BRAF. I did not.
BRAF you mentioned, yeah, fair enough. In addition to these actionable mutations, are you looking at any other results from the report? They might not be directly actionable, but maybe they're prognostic or relevant in some other way?
I don't know. HER2 is also, HER2 amplification or HER2 mutation is important too, and we are looking for that. There is, you can use so that was I did not mention. Other, exon 20 insertion mutation, T790 mutation, but exon 20, insertion mutations are important because there's there are probably 3 different drugs are being, well, at least 2 drugs are going to be approved anytime soon, and so that will be a mutation of interest as well.
Yeah, this is EGFR exon 20, correct?
You're right.
Okay, gotcha. Yeah. In terms of the testing process, at this time, is there any particular challenge or delay, anything that holds you up from offering this or conducting this testing for all of your patients?
Yeah, of course we want this to be done in seamless process, but it's still, it takes about 10 days to get this results, 10 days to 2 weeks.
Okay. Yeah, do you have to treat some patients ahead of that window?
or can you wait? But we would try to wait, but, in some cases, yes, ma'am.
Yeah, okay. All right, good. Let's move over to your frontline approach. You've already given me some hints here as to what happens, right, for patients who don't have a druggable mutation. Right, it sounds like they're getting a checkpoint inhibitor with or without chemo, correct?
Right. Yes, ma'am.
Okay. Yep. And then we talked about your second line. Most of those second line patients move over to a taxotere-based regimen.
Yeah.
Do you ever consider giving them a checkpoint inhibitor again? Perhaps a different agent, but do they see that that class of drugs again? Okay.
No, I don't. I think once they are progressed, they are done.
Understood. All right. And then one other thing to check on is whether the biomarker testing is ever repeated at the time of progression. Do you look again?
Yeah, that's a good question, and I have started looking at it. I was not doing it all the time, but now I would like to do it with a liquid biopsy. Yes, ma'am.
Why? What's changed?
Well, would like to know there's nothing, any new evolving mutation where I can target, you know.
Mm-hmm.
Mm-hmm.
Okay. Do you have any pushback now from your payers or your network, some other parties?
Yeah,
Is this a challenge at all?
you're right. I have not done significant amount of it, so I would not say that I have pushback.
Okay.
When I started doing it regular basis, I may come across some pushback, you know.
Yeah. Yeah, we'll see. Are you rebiopsying at this point, or is it a blood test?
Yeah, so biopsy is difficult because a lot of patients don't want it. So I think if I have initial biopsy and tissue NGS, then subsequently I think a liquid biopsy is a reasonable approach.
Yep. Fair enough. All right, let's move to treatments in development for metastatic non-small cell. Is there anything on your radar, doctor? You mentioned those couple agents directed to exon 20, right, for EGFR. So those are on the radar. Anything else?
Well, not unless, you know, I mean, you tell me something different, you know, I really don't know. I mean, I'm pretty sure there's a lot of combination treatments are being tested in the EGFR mutation when they progress on the first line TKI, combining the three different approaches, you know, or combining the, yeah. So those sort of things are, you know, but pretty much otherwise same at this time.
Mm-hmm. Okay. I'm digging specifically for KRAS inhibitors. Have you heard anything about these in lung cancer?
Oh, yes. I'm sorry I didn't mention about it.
Oh, that's fine.
Okay,
what have you heard?
So let me tell you about it, KRAS. KRAS is KRAS 12G, KRAS G12C, about 12% cases. 2 drugs are going to be approved time today or tomorrow or whatever. And one is sotorasib, which is the MGen 510 sotorasib, and other one is I don't know which one is the company is, and I think that is Tex, which is a Tex 85 something, which is the adagrasib. So those are the 2 drugs are approved anytime soon also. Sorry, I don't know why I did not mention it.
No, that's fine. Don't worry about it. Not a problem at all. Clearly, you're familiar with these. How have you heard about them?
Well, I think, you know, one is that we need it. I don't know why I'm surprised that FDA has not approved it. I don't know what's holding them. You know. And I think the both drugs should be approved. You know, on the phase 2 data, single arm, that's enough. But how I know that? Well, I know since the last 2 years, about a year and a half ago, about you know, an Amgen 510, which is turned out to be, which its name is now sotorasib, and then the other drug was now is adagrasib, you know. So I know about their data. How long I know? I've been knowing it since the data is presented. I guess if you now I may be in too many conferences. I think original data was presented by Dr. Ramaswamy Govindan in ESMO 2019 about AMG 510. So that's where the story started.
Mm-hmm. Okay. Do you have any hints at this time as to whether these 2 treatments that you've mentioned, adagrasib and sotorasib, are they distinctive at all?
So, okay, so that's a very good question. Now, okay, well, so the detail is this. I think they are a little bit distinct. I think there is a little bit of response rate. So one is 2 things. I think the half-lives are different. One is you know, so half-lives are different. You are trapping the G12C in an inactive state. So the question will be that which drug is going to keep them, you know, for. So I think that the dosing is different. I think so basically you are a pharmacist, so you know pharmacokinetic and the dynamics are slightly different. I think one drug will be a once a day, half-life is different. I think response rates are slightly different in the first line, second line. Majority of the data is on the second line because it's most of the patients are treated, so response rates are slightly different within the first line, second line. I think half-life is different. And also G12C mutation in other tumor types, such as the non-lung, which will be a, whatever.
Yeah, colon cancer, pancreatic.
Colorectal, gallbladder, and those does not have as much response as the lung one, but they have a good DCR control rate. I don't, maybe this is the best I can tell you at this time.
Oh, that's perfect. Yeah, I was curious, though, the point you're making about pharmacokinetics and dynamics, so what? Is there a particular clinical distinction in light of what you understand to be the kinetic differences?
Not really. I'm pretty sure the difference will be the clinically will be the dosing once or twice a day, and half-life will be matter. I'm pretty sure data will matter which one is effective. I think the response rate are about in mid and high 30s and mid 40s. I don't think there's a
Yep. And then the other possibility could be a difference in toxicities, either the nature or the rates of toxicity. Is that your understanding to any degree?
Yes. Yep.
Have you heard of any real distinctions between the two of them?
No. I thought that you were going to tell me today because you're a pharmacist.
Well, I have some material to share, and you can check it out for sure. All right, let's jump over there. All right, so I have product Y on your screen. Can you confirm that you see the full page? You can adjust it if you don't.
Actually, I don't because half of them is cut out. Now
Does
I
that
see
help?
the whole. Yes.
All right, very good. Please take a moment to read through it. Let me know when you're ready to comment.
So 37 DCR, 80% median duration of response. This looks like a sotorasib. And the 960. So this is sotorasib once a day. And so okay. So yeah, I know that. Yeah. Okay. Good.
Tell me about the data that you're seeing here, the features of this drug. What stands out to you?
Well, I mean, this drug I'm familiar with, as I said, I think it's a sotorasib 960 milligram, and it's a 30 oral response rate is 37, that's about right. DCR is 80%, that's about right. And diarrhea, nausea, other enzymes, and those are being common. So, yeah. So nothing, so kind of, yeah.
So no surprises, I guess, compared with where you what you understood.
Yeah.
All right.
Yeah. No
Right.
surprises. Yes.
As you refresh your memory about this treatment and looking at the different features here, the data, what are the biggest positives, advantages that this product Y might bring to the table?
Well, one is that these patients does not have a good prognosis. Number two, I mean, this is a very effective treatment option. Excuse me, in an entirely different target being relatively common, 13% in all non-small cell lung cancer. That's a huge patient, and so everything is positive. I really don't see any negative.
Okay. All right. Would you comment on the dosing for me, please? Looking at the details, the 8 pills, what is your reaction?
Yeah, so, yeah, I mean, it's not good, but what you're going to do? You have effective treatment, so you got to take it. I'm sorry. Yeah, I mean, it's not good in the sense, I mean, 8 pills is too many. So reaction is negative. Question is, it is going to deter to prescribe this drug? No.
Or does it affect patients' ability, willingness to take it?
Yeah, I mean, so that is, yeah, I mean, nobody's going to like 8 pills. So I'm just being honest. But, someone has a lung cancer, metastatic, I mean,